Mr. Lamb, can you unmute and count to 5 real quick, please?
1, 2, 3, 4, 5.
Great, thank you.
Are the meeting platform hosts ready to begin?
Yes.
Madam Chairwoman, are you ready to begin your hearing?
I am.
Please provide a 5-second countdown.
5, 4, 3, 2, 1. This meeting will come to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. The committee procedures for remote hearings remain the same. If you're experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved right away. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearings@mail.house.gov. Without objection, members will be recognized in order of seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the procedure for this hearing? Seeing none, we will proceed, and I will now recognize myself for an opening statement. Good morning. Thank you all for joining us today for the Health Subcommittee's oversight hearing on VA's community care program. Between fiscal year 2017 and fiscal year 2021, VA spending care from community providers grew from $10.1 billion a year to $21.8 billion a year. That's a 116% increase over 5 years, and this excludes costs associated with administering the program. Over the same period, investments in health care provided directly by staff at VA medical facilities grew only by 32%. Such significant growth in community care expenditures warrants oversight. Why are VA's investments in community care so vastly outpacing its investments in in-house care? How is VA coordinating care in the community and monitoring its quality? What oversight is VA conducting to ensure its third-party administrators are delivering on their contractual requirements, including building adequate networks of community providers? While VA's spending on community care has risen significantly since it implemented the Mission Act, the eligibility expansions in 2019, my colleagues and I regularly hear from veterans that they are still experiencing significant delays in receiving community care referrals. We hear all the time from veterans who have waited weeks or even months for community care appointments to be scheduled. I can't even fathom how much higher VA's community care expenditures would be if the program was operating perfectly, efficiently, and effectively. So unfortunately, this committee's ability to fully assess this program's status has been considerably hampered. From the fall of 2018 until early 2020, in the lead up to and immediate aftermath of implementing the Mission Act, VA community care officials provided monthly briefings for community staff. Those community care briefings came to an abrupt halt with the onset of the COVID-19 pandemic, and more than 2 years later, they have never resumed despite repeated requests from committee staff. Now, when our staff requested ad hoc briefings with VA community care officials, it usually takes weeks, if not months, for them to occur. At some point, VA began sending the committee bi-monthly slide decks from VA's Office of Community Care. These often lack sufficient detail about community care utilization and expenditures, and many times raise more questions than are answered. Slide decks are no substitute for bidirectional communication. It has been more than 5 months since the last community care briefing VA officials provided for committee staff. Many other VA program offices with far narrower responsibilities and far smaller budgets routinely provide quarterly and even bi-monthly briefings for the staff. Aside from this, VA began a process more than 9 months ago to realign the responsibilities of the Office of Community Care. It is in the process of shifting financial functions to VA's Office of Finance and merging the program operations side, merging the program operations side of the community care with the Office of Veterans Access to Care, which until now has only been responsible for in-house care. After the merger is complete, these offices will become the Office of Integrated Veteran Care. To date, VA has provided all of one briefing on the status of standing up this new office. VA's lack of engagement on community care and this ongoing reorganization is, to me, unacceptable. Thus, we are here today to conduct an oversight hearing, which is our responsibility to do. I look forward to today's conversation and to engaging with all of our witnesses. And with that, I'd like to recognize Ranking Member and General Bergman for an opening remarks he may wish to make.
Thank you, Chairwoman Brownlee, and it truly is great to be here in person, and I thank our witnesses for being with us today on both panels. I've been advocating for today's hearing for almost a year, and I'm excited to finally be here for it this morning. Ensuring that veterans can get the care they need when and where they need it should be the #1 priority of the VA healthcare system each and every day. There is nothing more important than that. It is quite literally a matter of life and death for veterans across our country. That is why it is so infuriating and frustrating when VA fails in its mission to ensure timely access to care for veterans in need. And frankly, VA fails too many times in this endeavor over the past period of time. To be clear, VA has a tough job. In most cases, you do it very well. I'm grateful for the many times that VA gets it right, and veterans' lives are saved or improved as a result of your efforts. But our offices hear on a too frequent basis from veterans who have had the opposite experience. We will discuss some of their stories today. They're harrowing. These veterans need VA's help. And when they ask VA for it, VA potentially tells them no, or makes them wait, or offers them some alternative, something else instead. That's really not how it should work, and more importantly, it is not what the law requires. My staff has spent the last several months talking to veterans, community care providers, and VA staff members across the country. I have collected testimonials from some of those individuals whose names I have removed to protect their confidentiality that I'd like to add to the hearing record.
Without objection.
Thank you. I believe these testimonials are representative of what millions of veterans nationwide go through every day. We are here today representing them, and I hope that subcommittee members and VA witnesses will keep their stories on your individual frontal lobes. On the second panel, we're going to hear from the minority witness, Forge Health. Opponents of community health care will tell you that non-VA providers lack the cultural competency to care for the unique needs of those who've served. Forge Health is veteran-owned and has a deep understanding of the meaning and impact of military service. Opponents of community care will tell you that it's just a backdoor to privatization on the part of those who want to do away with the VA healthcare system altogether. That's just simply not true. Forge Health believes, like I do, that community care only makes VA stronger and better able to provide the care that veterans require. Opponents of community care will tell you outcomes in the community are much worse than in the VA. Forge Health is a VA community care provider and partner, and they have the data to prove that. When VA works hand in hand with community providers, outcomes improve and veterans benefit. But Forge Health will testify later that even with all that, a veteran-specific skill set, support from the VA healthcare system, and a strong, proven partnership in place, it is still way too hard for veterans to get the community care they need. Forge provides support for veterans with mental health and substance abuse disorders. It's not easy for anyone to admit that they need that kind of help. And it can be impossible to reach them for follow-on, again, if they take the brave step and it doesn't get them anywhere initially in their time of need. Overdose deaths are skyrocketing in our country. Almost 20 service members and veterans continue to die by suicide on a daily basis, most without having had any contact with VA beforehand. VA has to stop. 1, stop making excuses. 2, stop acting like the community is their competition to be kept at an arm's length rather than their partner to be brought into the fold. And 3, stop putting more government bureaucracy, more red tape, and delay after delay after delay between veterans and the care they need. To do anything less than that would be to continue to fail the men and women that the VA was created for. And that is an unacceptable outcome for me. I hope to hear the same from VA this morning. With that, Madam Chairwoman, I yield back.
Thank you, General, and I'll now welcome our first panel from the Department of Veteran Affairs. Dr. Miguel Lapuz will deliver the department's oral statement. He serves as the acting Deputy Undersecretary for Health at the Veterans Health Administration. He's accompanied by Ms. Laura Duke, VHA's Chief Financial Officer, Dr. Julianne Flynn, VHA's Acting Assistant Undersecretary for Health for Community Care, and Dr. Lisa Arfons, Senior Medical Advisor for VHA's new Office of Integrated Veteran Care. Welcome to you all, and I will remind our witnesses, just because we're being recorded here, to pause for 2 or 3 seconds before speaking so that the recording will capture all your words, and please remember to do so again when answering members' questions. So VA's written statement will be included in full in the hearing record without objection. Dr. Lapuz, I now recognize you for 5 minutes for VA's remarks.
Good morning, Chairwoman Brownlee, Ranking Member Bergman, and members of the subcommittee. Thank you for the opportunity to discuss how VA provides veterans with world-class integrated care. I'm joined today by Ms. Laura Duke, Chief Financial Officer of VHA, Dr. Gillian Flynn, Acting Assistant Undersecretary of Health for Office of Community Care, and Dr. Lisa Arfons, Acting Deputy Executive Director, Office of Veterans Access to Care. I apologize for the late submission of our written statement and appreciate the committee's understanding. The Veterans Health Administration's employees, one-third of whom are veterans, come to work every day with one goal in mind: to serve veterans, their families, caregivers, and survivors with the same honor and commitment when they served our country. Our employees prove daily that we will face any challenge and go to any length to ensure veterans receive the care and services they have earned and most certainly deserve. Their dedication and our efforts, made possible through Congress's support, have made VA one of the top 5 best places to work among large federal agencies, the first time this has ever happened. We thank this committee for its leadership in making this achievement possible. VA is working hard to lead through the pandemic and beyond. We want veterans, their families, and beneficiaries, caregivers, to know that our sacred obligation includes ensuring access to the high-quality health care they trust, whether they are in a VA facility receiving VA care virtually or seeking care in the community. VA is proud of the more than 1.2 million healthcare providers that serve veterans in the community and amplify the excellent care provided through VA's direct care system. Notably, however, veteran trust in community care lags behind trust in VA's direct care system. Quality of care is more difficult to measure and monitor, given that private sector systems generally do not collect or report the depth of quality data that VA shares for its direct care system. To enhance community care quality, VA has made internal clinical training available free of charge to community providers and has created focused training on traumatic brain injury, post-traumatic stress disorder, military sexual trauma, suicide prevention, and military culture. VA also collects and reviews information about veterans' experiences in the community and analyzes customer experience data and insights in real time to inform service recovery and performance improvement efforts. As VA continues to focus its efforts on veterans' experiences, access, and outcomes, it is important to note that community care growth does not appear to be a result of veteran preference and may instead be influenced by other factors, like the distance to the nearest VA emergency department. Veteran experience data indicates veterans generally prefer and have greater trust in VA's direct care system. Additionally, as the community care aspect of VA system has expanded, we have heard from veterans, community care providers, and VA employees that the separate VA systems for scheduling and accessing direct VA care and community care are not customer-centric. Providing the best possible care to veterans and allowing them to take charge of their own healthcare journey is the goal of the new Office of Integrated Veteran Care, or IVC, where VA staff empower eligible veterans by providing them with information that allows them to make informed choices about where to receive their care, whether in a VA facility or in the community. The goal is for VA and community care providers to work hand in hand to provide world-class care to veterans. For example, a Vietnam-era Marine veteran who receives his care at the George Wallen Medical Center in Salt Lake City was diagnosed with multiple myeloma, a type of blood cancer. VA coordinated his care and treatment options with the University of Utah's Huntsman's Cancer Center, or Institute, while the Institute provided the veteran stem cell transplant. His pre-transplant treatments and follow-up care was at the VA Medical Center, a collaboration the veteran praised as a great partnership. Care coordination is a critical need for veterans, and we are working to ensure that our delivery system is designed around veterans' needs, not VA organizational requirements. VA is committed to serving our nation's veterans. We are proud of the trust and quality we deliver through our direct care system, and we continue to strive to ensure quality in our network of community providers. VA will continue to focus on excellence in access and outcomes, concentrating our efforts on what matters to veterans and their families, caregivers, and survivors. Chairwoman, Ranking Member, and members of the subcommittee, thank you for the opportunity to testify before the subcommittee today to discuss one of VA's top priorities. My colleagues and I are ready to respond to any questions that you may have.
Thank you, Doctor. And I will now recognize myself for 5 minutes of questioning. The first question I wanted to ask Ms. Duke, I think we're all in agreement that the spending on community care is getting to an unsustainable point. And as VA considers updating its designated access standards, can you speak to an analysis you've done to determine which eligibility criteria and/or current designated access standards have really driven the significant increase in community care costs over the last several years?
Thank you for the question. And first of all, I'd like to say that when we consider eligibility for community care, we don't really break out which of the eligibility criteria is responsible for the referral, because the fact is multiple criteria may apply to the same veteran as opposed to what gets recorded in the system when they get sent out. So it's very hard to parse that data, and the data that we have is not extremely helpful because it's not complete. But that said, I think what you've seen in terms of the growth in the community care resources that have been requested and allocated over the last couple of years is a reflection of the expanded authority to provide additional opportunities to access care. At the same time that we've seen the community care budget grow, we've also seen the direct care budget grow as well. And in particular, I think we're still trying to get our arms around the impact of the Mission Act because of the interfering impact of the pandemic, during which time we saw very different behavior in the direct care system and the community as a result of the fact that VA was able to focus on providing additional protections for its most vulnerable veterans. So I apologize that we can't provide detailed data, but I can say that the veterans who are eligible for the community, just because they are eligible, they're still offered the opportunity to come into the direct care system, and it's our commitment that our budget fully fund however many veterans choose to stay with VA.
Well, thank you for that. It seems to me that, the two primary pieces of criteria are, and they're either or is time and distance. And so, what's most frequently recorded between those two?
So what I can say is in our budget formulation process, when we're developing the president's budget, the distance is the one that's most able for us to look at, because we have demographic data on the veterans who would be eligible based on distance. With the time, that's such a variable factor, and that's part of why we're committed to providing updated data on what those time factors are, so that you and our veterans have a better view of what to expect when they come in and seek care.
It seems to me that when we look at wait times, which is one of the criteria, it seems to me that still one of the larger problems here, and I think General Bergman sort of referenced this in his opening comments, is generally, on average, the 21 days or that it sort of takes when the veteran calls into the VA to the point of actually getting back to the veteran to kind of schedule an appointment. So that's 21 days, and then, it depends. 20 days is a criteria, and 28 days is another. So you tack on the absolute that's generally going to happen, you're suddenly at that place, where you have to offer the veteran an opportunity to go into the community. And we're learning that, in the community, they're not necessarily getting appointments a lot faster. So I'm just wondering, are you looking at that? I know that you're re-looking at how you calculate wait times. I was in a meeting with Dr. Braverman at West Los Angeles. He talked about it coming online like next week, but is sort of dealing with that 21-day, beginning. Is that going to be addressed at all?
I'd like to hand that off to my colleagues who are more in touch with the new debut of the data.
Yes, ma'am. And that is exactly the reason why we stood up the Office of Integrated Veteran Care. That is, so then we have a good idea of what is happening in the VA direct care system, as well as in the community care scheduling system. So we now have an IPT to deal with this in order to look at solutions on how we can facilitate scheduling.
Very good. It looks as though my time is up. Thank you, and I will now recognize Congresswoman Radewagen for 5 minutes of questioning.
Thank you very much, Chairwoman Brownlee and Ranking Member General Bergman. And thank you all for being here today to the panel. Welcome. Dr. Lapuz, Forge Health is going to testify on our second panel about a veteran they worked with who needed specialty care 3 times a week and lived more than an hour from the nearest VA medical facility that could provide that level of care. According to Forge, that veteran's attempt to be referred to the community was denied by VA. Do you think it's appropriate to ask a sick veteran to spend at least 6 hours every week driving to and from a VA medical facility? Yes or no?
It is always the goal of VA to deliver the best access and the best outcomes, as well as the best experience for the veteran. And in this particular situation, ma'am, we don't have the specifics of the case, and it will be our privilege to actually look into the specifics of the case and provide you with the information.
But was it yes or no?
I'm sorry, ma'am.
That was my question. Was it yes or no to my question?
If the question is, did we not meet the standards of the eligibility requirement, we would like to be able to look into this question, ma'am. It's a very specific situation, and I could not, in general terms, provide you with the information without looking into the specifics of this particular situation.
All right. Is it VA's policy, generally speaking, to deny a veteran in those circumstances the ability to seek care in the community? Yes or no?
No, ma'am.
What recourse would a veteran in those circumstances have to seek a reversal of that denial?
The veteran can actually approach the patient advocate and actually file a complaint, and that complaint will actually get into the Office of Community Care, and that we will be able to respond to that veteran's concern appropriately.
Okay. Dr. Lapuz, are VA medical facilities in any way discouraged from referring veterans to community care or penalized financially or otherwise for making those referrals? And if not, what do you make of the multiple reports that we've received from veterans, community providers, and others, including some VA staff who wish to remain anonymous out of fear of reprisal, who have heard of official or unofficial VA policies across the country to the contrary? And what are you going to do to correct the record on that across the VA healthcare system?
It is never the policy of the department to deprive any veterans of their eligibility to community care. We follow all of the laws, the regulations, and policies in providing veterans access to community care. We are looking at each of the specifics of the situations whenever veterans felt that they were denied community care access inappropriately. And it is our hope that because we have now one office that can actually consolidate all of these concerns, that we can systematically deep dive into all of these reasons and why they were denied, and that we can put proactive measures in place to avoid future unfortunate events.
Thank you, Madam Chair. I yield back the balance of my time.
Thank you, Ms. Radewagen. I now recognize Congressman Sablan for 5 minutes of questions. Mr. Sablan?
Yeah, good morning, Madam Chair and Ranking Member Bergman. Thank you for holding this hearing. Dr. Lapuz, Mr. Secretary, multiple community care providers in my district have reported to me that the VA is behind on thousands of dollars of payments to reimburse veteran care, some of which have been outstanding for over a year, I'm made to understand. As an example, one such provider told me that they have been waiting to be reimbursed some $15,000 related to veteran care and since 2020. Other vendors are facing similar issues. So we have raised these issues to the regional staff in the Hawaii office, but they remain unresolved. Why is it taking VA this long to pay community care providers, and what is being done to resolve this issue?
Thank you for the question, sir. It is our intent to maintain excellent relationships with our community providers, and through the years, we have demonstrated that we have provided improvement, significant improvement in the payment timeliness. And I will turn it over to Dr. Flynn for the specifics on this question.
Thank you, sir. We were challenged in the past with timeliness on payments, and we have made significant improvements. But I really would like to know the specifics on these cases, sir, and we'll dig into them and figure out what is holding them up.
Well, thank you. And I didn't expect an answer on these claims right here and then, but just, the thought that this may be happening out in some region on the far edge of the earth. And we appreciate you looking into it, and hopefully we can have some resolution of this. Thank you very much, Madam Chair. Do you need my time, or should I yield?
You may yield.
Thank you, Madam Chair, I yield.
Thank you, Mr. Sablon. I now recognize Congressman Rosendale for 5 minutes of questions.
Thank you, Madam Chair, and thank you, Ranking Member Bergman, for convening this hearing today. Dr. LaPuz, while I appreciate your anecdotal success story about a veteran's treatment, I assure you that I could share many, many stories about veterans who have experienced extreme waiting times for appointments and have been directed to faraway facilities with no means of transportation to be able to get to those facilities, and then mix-ups and confusions after arriving at those facilities. So we have major issues, and this is why the veterans are trying to receive care in their communities. And I think that we all have an obligation here not to prop up the Veterans Administration.
Timer at 9 seconds.
Mr. Sablon, you need to mute.
Not to prop up the Veterans Administration, but to focus all of our attention on making sure that our veterans get the health care that they have earned, that they deserve, when they need it, where they need it. That's what we need to be focused on. I'm pleased to hear that the VA believes it needs to design its care delivery around the needs of the veterans, and I'm sure you're aware of the 2020 GAO report that outlined a 7-step process before a veteran can even be seen by a community provider of his or her choice. Meanwhile, your statement in your introduction was that you even recognize that the process is not consumer-concentric, okay? They're not receiving the care that they need when they need it. Is this process still accurate, and do you believe that the 7 steps is acceptable?
So first of all, we are as committed as you are in ensuring that we are providing the best access, the best outcomes, and the best experience for our veterans. And I know that the over 300,000 employees of the department, that every single one of them is committed to ensuring that the veterans receive the care that they deserve. Now, we are confident that the trust scores, for example, in the veterans' experience for the direct care is at about 90%. So there are, the majority, a vast majority of our veterans are very happy and satisfied with the care that they are receiving, and thus providing us with the feedback that, in fact, we have a trust score coming
Dr.
from.
Lapuz, I understand all that. Look, I can quote statistics and data all day long, okay? Maybe I'm just getting the 10% that's not happy because they didn't go to the Veterans Administration. What do you feel about the 7-step process?
But regardless, like I'd like to address it. Of course, there will be some veterans that will be unhappy, and this is the one that we're striving continuously to ensure that we have an understanding of their journey through our care system, whether that's a direct care system or the community care referral system, and that we are, and again, that is the focus of the new integrated veterans care, to understand the veterans' journey. And I'd like to call on Dr. Flynn to provide additional information on that.
I'll agree with Dr. Lapuz. We've made strides, but we're not happy with where we are, and we want to be better for all veterans, not just the 90%. This new office, I can tell you from my perspective as my permanent job as a chief of staff in San Antonio, the 2 program offices, there's room for efficiencies and a better, more seamless approach for our veterans. And that's our goal, and that's what this new office is going to strive for. That's the vision.
Okay, Dr. Lapuz, if this is about the veteran's need, okay, this is what we continuously talk about. Shouldn't the veteran decide what he needs?
Well, the eligibility requires that it is first medically appropriate. So, and if they're eligible, now the veterans has a choice to go to the community provider and a choice to actually stay within the VA.
Okay, so let me ask you this. Why does a veteran, let me make it real simple. Why does a veteran need to see the VA just to be seen outside of the VA? Especially when you're living in a very rural state like Montana, where you may have to travel literally hundreds of miles to see the VA before you can actually go and see a physician. Why should we have that?
The VA is to ensure that we're providing the best access, and that there is a best outcome. So in other words, there is a requirement that we have that we are able to oversee that particular process, sir. And that is the reason why we are ensuring that through that process of going to the VA, that we are able to have a clear oversight and a good oversight on the healthcare journey of that particular veteran.
Okay, well, Madam Chair, I see my time is up, but I would just like to say that it seems to me that if we have a veteran that has to travel several hundred miles just to see a primary physician, to then direct them to somewhere else, that would be accommodated a lot better closer to home. Thank you, Madam Chair.
Rosendahl, now recognize Congresswoman Underwood for 5 minutes of questions.
Thank you, Madam Chair. Today's hearing is an important opportunity to examine the quality of care that veterans are receiving outside of VA facilities, including maternity care. Although VA covers maternity care, it's only provided by non-VA healthcare professionals in non-VA facilities. So for pregnant veterans, community care isn't a matter of preference, it's a necessity. That's why I introduced the Protecting Moms Who Served Act, which will improve the quality of maternal health care services that veterans receive. This bipartisan bill was signed into law last year and authorized funding to enhance coordination between VA and community maternity care providers. The fiscal year 2023 Military Construction and Veterans Affairs Appropriations Bill includes language directing VA to implement and fully resource this new law. Dr. Lapuz, with additional funding from my bill to enhance VA's maternity care programs, how will the department better serve the growing population of pregnant and postpartum veterans?
So, ma'am, we would like to thank you for your support for women's veterans, particularly those who are requiring maternity care. And because of that, we have maternity care coordinators in over 100 medical, or rather healthcare systems. And the maternity care coordinators are able to provide wraparound services to veterans who are requiring maternity care, to include postpartum care, and to include counseling for intimate partner violence situations. And we are very grateful that, that at this particular point, the 6,000 women veterans who are requiring maternity care every year coming from the VA, we are now able to provide better services through the utilization of the maternity care coordinators, and that they are now having a full access to the wraparound services wraparound services that are part of our women's veterans program. And those services include social worker support, mental health professional support, nutrition, and others. So this is a complete wraparound service, and that we are also case managing those veterans requiring obstetrical care, now extending 12 months beyond postpartum.
Excellent. I love that. Thank you so much, sir. So community care providers also have an essential role to play in preventing veteran suicide. One evidence-based suicide prevention initiative that VA implemented during the Trump administration was lethal means safety training requirements. These requirements mandate every VHA clinician undergo training to be prepared to have conversations with veterans about the intentional, voluntary practice of reducing suicide risk by limiting access to lethal means like firearms, medications, and sharp instruments. Thanks to this mandate, 97% of VHA clinicians have completed the department's training. However, training remains optional for community providers, and as a result, only 250 community providers have completed the training. That's out of a denominator of more than 900,000 active individual community providers who are eligible to take this optional training. 250. That means that if you're a veteran exclusively receiving care in the community, it is highly unlikely that your provider has been trained in this evidence-based suicide prevention principle, and that is unacceptable. My Lethal Means Safety Training Act would expand the Trump administration's training requirement beyond VHA clinicians to include all VA employees who regularly interact with veterans in their work, as well as community care providers and family caregivers. We need to enact this common sense legislation to ensure that veterans receiving care in the community are being treated by healthcare professionals who are appropriately trained in evidence-based suicide prevention measures. I'm committed to ensuring that this essential bill is signed into law, or VA implements the training requirement using the Secretary's existing authority. Our veterans' lives depend on it. Thank you, Madam Chair, and I yield back.
Thank you, Ms. Underwood. And General Bergman, I think Ms. Miller-Meeks is due to be here in about 5 minutes or so, but she's not here. And I know you wanted to go last, but I'm calling on you now.
Well, next is last right now,
There you go.
or currently. And if, I tell you what, are you okay if, when she walks in, that if I just yield my time at that point and we can go right to her? Okay, good. Number one, thank you for everybody being here today, because this is complex. You know, it's when the Mission Act was put into place, and then care in the community was adjunct or additional part, you know, the goal was simple: provide more care, more available quality care to veterans, and as Mr. Rosendale said, in rural and remote areas. Several of us have districts that not only is it long distance of drives, it's inclement weather, it's all sorts of things, and lack of internet and multiple factors. So, having said that, think for a minute of a flow chart. And on this side, on the beginning, before the Mission Act and before care in the community existed, is it fair to assume that the VA had a way for the veteran made a contact, whether it be a phone, via email, whatever, and then they entered into the system, and depending how they answered a question, they went to A or B. You know, they walked down a track based upon, is that a fair assessment? Okay. So, when we instituted the Care in the Community Act, if you had a number of boxes, wickets that they would go through, from the time they have initial contact till the time they were actually seeing a provider. Did the number of wickets increase, decrease, or stay the same?
Sir, it has tremendously
Yes,
increased.
the number, I'm gonna say it again.
Yes.
And you can be, you don't have to be, I don't care if it's 3 or 5 or whatever. As you assess the steps that the veteran and the VA and the community care provider have to go through, did that number of steps, said a different way, stay the same, increase, or decrease?
It has significantly increased, sir, and this is compatible.
No, we're gonna stop there because, Ms. Miller-Meeks, are you ready? Okay, I'd like to yield, stop and then continue on if that's okay.
I see that you have about 2 minutes and 2:02. And I now recognize Congresswoman Miller-Meeks for 5 minutes of questions.
Thank you, Chairwoman Brownlee and Ranking Member General Bergman. And General Bergman, yes, as an Army veteran, I'm always ready. Dr. LaPuz, thank you so much for being here. In your testimony, you emphasized the use of telehealth. And as a physician in a rural area and a former director of public health and a 24-year military veteran, it's very important to me. And since the pandemic, the VA has provided, on average, more than 40,000 telehealth visits per day. What lessons has the VA learned about providing quality care via telehealth in the VA and in the community?
Well, thank you very much for that question, ma'am. And what we have learned significantly from our telehealth experience, that first of all, that there is a majority of our veterans are amenable to having telehealth visits. So particularly those veterans that have experienced at least one telehealth visit. So what we have done is we have trained all of our providers to ensure that they are able to convince the veteran to at least undergo one telehealth visit, because the subsequent visits after that initial hesitation is actually, that acceptance rate is much higher. The second thing that we have learned is that for those that have gone through the telehealth, that they have a good preference to actually maintain the telehealth visits, although they are still requiring a face-to-face on occasion. So then that means that telehealth should not be exclusively offered, but be part of an option. And then thirdly, what we have discovered is that telehealth has a wide acceptance among VA providers, particularly among mental health providers. And that this is corresponding also to the acceptance rate of those veterans who are requiring mental health visits, and they have a good acceptance of a telemental health visit. And I'd like to turn over to Dr. Arfons for more.
If I can, I just want to follow up, and then I'm happy to have you turn it over. So as I mentioned, I'm a physician in a rural area, and also have, as a state senator, it was very necessary for us to get broadband and connectivity to not only veterans, to all of our citizens in Iowa. 15% of veteran households don't have the broadband to do a telehealth visit. And as we've seen, the VA has attempted to bridge the digital divide by providing phones and tablets to veterans who don't have internet access in their homes. However, that still has not materialized, and we know that there's an OIG report that is addressing this. But it is of concern to the Republican members of this subcommittee and of the Veterans Committee. This program has shown to be ineffective, as the phones and tablets have not been distributed, which also then brings up, are we wasting taxpayer dollars? In addition, I've also heard from veterans, and I think you addressed this, that they would prefer to have an in-person visit with their doctor. And as you mentioned, face-to-face is an option. You're not mandating that they have telehealth visits. So what's the VA doing to ensure that veterans have the option to visit with doctors or providers who they want to see without worrying that telehealth will prevent them from seeking community care? And what's your stand on community care? As I said, I'm in a rural area, and so for some of my veterans, they're traveling an hour and a half to 2 hours one way in order to go to a VA facility to seek face-to-face care.
Dr.
Thank you. Yes, so veterans always have the option to come see us face-to-face or telehealth. We never want to force them into only getting a telehealth visit, as you mentioned, if they're not comfortable, if they're not capable, or they simply just clinically need to be seen face-to-face. So that option is always available for them. We don't want to box them in. We do offer telehealth in the community as well. As Dr. Lapuz mentioned, often mental health can be delivered both within VA and in the community. So we right now have no restrictions on telehealth being offered in the community if that's easiest for veterans as well.
What about receiving community care?
Oh yes, they can receive community care in terms of.
And so you're not putting up barriers to individuals receiving care in their community?
No.
From a local provider who is available, ready to see them?
Correct.
Without a waiting period?
Correct.
All right. Thank you very much for your answer. I'm just going to say, as a 24-year military veteran, my husband is a 30-year veteran. 6 of the 8 children in my family were in the military. My father was an Air Force veteran as well. And as a physician, I have no higher priority than to ensure that quality care is provided to our nation's veterans. Thank you, and thank you, Representative Bergman, for yielding time to me, and thank you, Representative Brownlee, Chairwoman Brownlee, for holding this subcommittee. Thank you very much. I yield back.
Thank you, Congresswoman, and I will now go back to General Bergman, and I think we're going to have a second round of questions if we can. So, Mr. Bergman, if you want to go a little over your 2.02 time, yeah, you're welcome to. Then I'll ask another question, and if other members have other questions, we can go to you.
Thank you. Thank you, Chairwoman. So getting back to the flow chart of the wickets jump through, what I heard you say, Doctor, was one of the things the VA had to do was, now this is my interpretation of your words, increase its oversight of the community care providers to make sure they were doing their job. Why? So let me say it a different way. Why wasn't there a criteria for accepting a care provider and then enable them delegate the authority to do it, their work? I mean, VA ultimately has the responsibility. You can delegate authority, but you cannot delegate responsibility. But are you telling me that we, as the Veterans Affairs Committee in the Congress, accidentally, through our efforts to provide better care in the community for the veterans, caused the VA to increase the size of a already largest bureaucracy in the United States government?
With the introduction of the care to care in the community, what has happened is that the veteran is now exposed to all of the experiences that I personally, when I'm seeking care in the community, is exposed to.
Yes,
and that,
just that we can keep these very simple. Did the VA size of the VA bureaucracy increase because of what we tried to do in implementing care in the community?
So the healthcare delivery system in this country is complex and complicated.
I know.
And once
but
that is opened up.
A simple yes or no, because it could have increased over a short period of time to get this implemented and then backed off as it got up and running. Or I don't know. Can you give me a clue?
So the veterans is now exposed to the same healthcare delivery system that is available out there in the community. And the VA is tasked to integrate this. So this is the greatest task now, sir, for the VA. That is to integrate a very complex and complicated healthcare delivery system and to offer the veteran a well-integrated and coordinated care system. So my experience is if I go to a healthcare provider, I go to have my lab, I go to have my x-ray, and I go to a specialist, And I, as an individual, will have to integrate all of that. Now, the VA is the one that is doing the integration of all of that complicated healthcare delivery
I
system
got-
that is available in
I
the
hope-
private sector.
The one thing you can't recapture is time. So I'm going to kind of, is there, if I was to say I agree with and support what you're doing, is this a ramp up for the VA and then it ramps down because you got it up and running? Or are we continuing on a path here where through bureaucratic efforts, maybe unnecessary in some cases, the VA has just added more bureaucratic weight, W-E-I-G-H-T, and then adds to the weight, W-A-I-T, of this whole situation? Because we're trying to get care to the veterans who are, again, largely rural and remote, not within the VA system. So what I'm hearing you say in different ways is that the VA is just, the bureaucracy is continuing to grow to implement a program that was actually designed to streamline the access of care to veterans, largely in the rural and remote communities, so that they could actually identify them and get them in most cases, to the VA system where appropriate.
The bureaucracy, sir, has not increased. The task of integrating a difficult within the context of the community care is the one that has increased. That task for the VA to coordinate the care from different providers to ensure that the medical records are in one particular location that all of the providers in the community will have access to provide, to prevent.
No, I've got it. We're, Chairwoman Brownlee, I yield back.
Thank you, General Bergman. And I will now allow myself to ask a few more questions and allow myself some more time. So the first question that I really wanted to ask, I always feel like when we have these hearings, we should have the second panel go first and have VA go last, that would be a more effective use of our time, because they're going to raise issues that you won't be here to answer. So there's one question that I wanted to ask based on reading Forge Health's testimony. They testified in their testimony that that all intensive care outpatient claims are being denied, and that they have been told by the VA that intensive outpatient care has been removed as a covered service. Can you tell me whether that's true or not?
I'd like to defer to Dr. Flynn for it.
Thank you, Dr. Lapuz. So I read the testimony last night, and I believe it takes a community to take care of our veterans. We cannot do it all ourselves. I want to work with Forge Health to figure this out. We do offer IOP internally to the VA, and I do know that we send veterans out for IOP programs when we don't have access.
Okay.
I just don't have.
Well,
any-
if you could figure this out, because they really are operating, and I think they're, doing a good job servicing our veterans and a good place to make referrals to. And if a veteran needs intensive care, outpatient care, they're in really dire need, and they need it now, not later. So if you could get that worked out, I'd appreciate it. My other question is, it seems as though the Office of Integrated, this new Office of Integrated Veteran Care is the panacea solution to, all of the problems that Choice have, that Mission has, and it's going to solve this issue on an integrated basis. But it seems still to us, and I think to my staff as well, is that it's still very fuzzy. I understand what integrated services means, and I think that that's, probably a good way to go. But, there's a lot of functions that go into all of this, and how you're going to integrate it. What are the timelines? When are you going to be up? We don't have answers really to any of that. And we know these problems are out there and they exist, and they need to be resolved. And sometimes it takes, years to stand up a new program. And we don't have years. I mean, if you're going to build a new program, you've got to be kind of solving these problems as you go until the program is completely stood up and working. So if you could help us to understand that. And so, you know, and just a couple of questions under this Office of Integrated Veteran Care. Will you still contract with TriWest and Optum under the new system in terms of them? You know, they're servicing, I think, 23 or 24 medical centers in terms of doing the appointment scheduling and so forth. Will you continue to do that? Will you integrate telehealth into all of that? In other words, I mean, we've talked a lot about telehealth, but you know, if we use telehealth to contact a patient and to make the assessment whether they should go into the community for the care, that can happen like right away, as opposed to traveling 2 days to get to a facility or 6 hours to get to a facility. And you know, one thing that we haven't talked about here at all is one of the, I think, primary problems why this isn't working as well as it should is that you're understaffed by about 1,300 staff vacancies. So, you know, tell me how integrated, a new integrated system is going to solve all these problems. And when is the timeline, and when are you going to stand it up? And, you know, it's our responsibility to oversee this and to make sure, you know, we're not here to just get after you, because like many of us have said, I think you do a very good job in many, many, many respects. And there are a lot of happy veterans out there that we don't talk about. But we do talk about what the issues and the problems are, because we want to collectively improve. And I know you want to improve as well. But so we're not, you know, here to admonish, we're here to be helpful. So if you can tell me what the timeline is and how this integrated system is going to just solve a lot of problems that we're talking about now.
Ma'am, we would be happy to work with your staff to provide them with the briefing so that we can provide the timeline. And I think that we promise to do a better job in informing the committee and making sure that we provide briefings. But the whole idea here is to build a VACO organization that will track the journey of the veterans as that particular veteran is going in and out of the VA system, that is the direct care and going to the community, and also all of our virtual care offerings. And we do have a lot of virtual care offerings at this particular point that will allow the veterans, such as our clinical contact center, that will allow the veteran to call a 1-800 number, a toll-free number, and that they will be offered nurse advice. And in the future, and we already have 3 visits that are doing this, that they are even offered licensed independent providers. So they can be seen on demand at least in 3 visits at this particular point. And we have every intention that this is going to be nationwide. Now, as I've said, in order for us to convey all of the timeline, we will work with your with the staff to continue our briefing, and we will do a better job in briefing you, ma'am.
Well, I appreciate that, and I think it's really necessary. We need to really be up to speed. I mean, all of us up here represent members in our communities, and sometimes we have to go home and we don't have answers to what veterans are asking. So it's important that we have answers and that we have solutions to provide them, even if we can talk about solutions that are coming, but be able to talk about solutions that are coming in a confident way that it's going to actually really happen. So I would really appreciate you spending time with my staff so they can update me and to understand, how this program is going to happen. Because there are a lot of moving issues, and as General Bergman says, it's complicated and it's complex, and I get that. And we've got all these VISNs and medical centers across the country who are autonomous in many ways and get to make their own decisions, and how to incorporate this on a nationwide basis that is consistent, from the West Coast to the East Coast and everything in between. So, including all the territories, if Mr. Sablon is still with us. So I would appreciate that, and I thank you I thank you all for being here, and if, Mr. Rosendahl, if you have another question, you have 5 minutes.
Thank you, Madam Chair. I hope, as Chairwoman stated, that you all will actually stay in and listen to the testimony from the community care providers coming up, because it's important for you to hear from them directly about the challenges that they're experiencing and the issues that they're experiencing in their interactions with the VA. Hopefully, that'll help us to resolve some of that. As the ranking member of the Technology Modernization Subcommittee, I assure you, as you've made reference to the data and the information being able to be accurate and shared easily between the private providers and the Veterans Administration, I am well aware of those challenges and have been fighting extremely hard for the last 20 months to try and bring some kind of resolution to that, unfortunately without a lot of support from Secretary McDonough, to be perfectly honest with you. And I'm quite disappointed in that, because I think it would help us resolve a lot of these problems. I think it would help us to streamline the very process that General Bergman was talking about, to make sure that we eliminate some of those steps and we can get that care delivered to our veterans faster. So, that all being said, we can't lay all of the problems on the threshold of this data system. So what I would like to hear from you, Dr. Lapuz, is what kind of changes have you made or recommendations have you made to address the input that you've received from the community providers?
Sir, it is our hope, and we're working towards this, to ensure that we maintain and expand our community providers, so then the veterans will have better access to
Sure.
better access
And
to
I'm
care.
sure because of that, the community care providers have certainly had requests and interactions with you. So what recommendations have you made or changes have you made as a direct result of those communications?
So I'll defer to Dr. Flynn for the specifics, sir.
Yes, sir. Sir, we have a program called HSRM, which facilitates documentation going back and forth. We've seen increasing use in community providers, and that would definitely streamline things if we can have even more providers use that. It's easier than faxing. It's right away. That's one of the many improvements. We meet very frequently with our third-party administrator leadership to get that feedback and what they're hearing, and we work together. Again, it takes a community to get this right, and so we definitely partner.
So the HSRM system is the one recommendation that you've taken from them and have implemented? Because we get complaints about the appointment process, we get complaints about the billing process. If we're getting those complaints, then clearly you have to be getting those complaints. So have you not tried to address, make recommendations, or implement any of the changes to improve the system?
So with regard to scheduling, sir, we actually have at this particular point a team that has looked at all of the requirements in order for us to improve our internal scheduling, our scheduling with community providers, our telehealth scheduling, and also veterans self-scheduling process. And we are anticipating that before the end of September, that they will come up with the requirements necessary in order to pursue a contracting vehicle that will allow us to come up with a solution. So if you can just imagine, sir, that having when you're working at a community care as a scheduling clerk, that you will have to call the veteran, call the community provider, and ensure that that particular schedule of the veteran and the schedule of that provider matches. Now, you can just imagine that this is a phone tag that is happening because both the provider's office as well as the veteran can be busy. And what we're trying to come up with is a technological tool that will allow us to schedule on site. So this is, while the veteran is actually with a particular clerk, that scheduling can occur. Now, so this is a solution in the future, but what we're working on right now is the requirement to come up with a contracting vehicle to get to that point. And this team has come up with 123 recommendations on how we're going to enhance the entire scheduling process to include getting documentations after the veteran has been seen by the community provider.
Thank you. Madam Chair, if you have, or if I could get my hands on these 123 recommendations, I would love to have that, please.
If you
Thank
could
very
provide
much.
that to the committee.
And I would yield back.
Thank you, Mr. Rosendahl, and I think that there's no further questions for the witnesses today. We thank you for your testimony, and we'll return now to our second panel, and you are certainly welcome to stay and listen to the testimony from our next witness. So we'll just pause for a minute to transfer the first panel to the second. We'll now move on to the second panel, and our second panel witnesses are Mr. Eric Freeman, co-founder and chief executive officer of Forge Health, and Mr. Eric Golnick, co-founder and chief executive officer for Forge VFR. Welcome to you both, and I understand Mr. Freeman will be delivering the oral statement on behalf of Forge Health. So welcome. We look forward to your testimony, and your written testimony will be included in full in the hearing record without objection. Mr. Freeman, you have 5 minutes to present.
Good morning, Chairwoman Brownlee, Ranking Member Bergman, and esteemed members of the Veteran Affairs Subcommittee on Health. I'm Eric Freeman, co-founder and CEO of Forge Health, and I'm honored to be here today to testify on our experience as a community provider working with the Veteran Health Administration. However, being here today to discuss the challenges we face in serving our veterans as a community care provider is somber, since, from our perspective on the ground, we see veterans facing bureaucratic obstacles to getting the essential care they need. The VA Mission Act was an incredibly important step forward for our veterans, but it is only as valuable as its implementation. Until it is implemented as intended, veterans will continue to suffer unnecessarily long wait times or be unnecessarily referred to a community provider, and in too many cases, will die as a result. My brother, Captain Jonathan Sidney Freeman, who is here with me today, served honorably as a U.S. Army infantry officer deployed to 2 combat zones, Iraq and Egypt. Since then, my brother has lost more soldiers to suicide and alcohol and drug-related deaths than he did overseas. And I'd really like that to sink in. My brother, a U.S. Army veteran, has lost more soldiers to suicide in alcohol and drug-related deaths than he did in 2 combat zones. That statistic is devastating and unacceptable. Unfortunately, this is a sobering statistic shared by many veterans. I, along with Eric Golnick, a former naval officer who suffered from post-traumatic stress and substance use issues, founded Forge Health in 2016 to lead the charge in driving innovation, improving care delivery, and shaping the future of behavioral health so that there is accessible, affordable, and effective mental health and substance use treatment for all. Our veteran and first responder services, called Forge VFR, has earned a strong reputation and the trust of thousands of patients by providing the highest quality, trauma-informed, and evidence-based mental health and substance use treatment designed specifically and tailored specifically to and for active duty service members, veterans, first responders, and their families. To be crystal clear, we're a veteran-led community care provider that is mission-focused on ensuring that veterans and their families receive the highest quality care that they need in a timely and efficient manner. We fundamentally believe that the VA is the most essential resource to a veteran's overall health and well-being, and community care serves only as a critical force multiplier to ensure veterans have timely access to essential services. Now, we've been partnered with the VA since 2018, and it's been a fantastic partnership thus far. We've worked hand in hand to increase the access to substance abuse and mental health services for veterans, and also strengthen their relationship with the VA. And this has been a successful partnership with evidence. Recently, Forge Health and the VA did a clinical outcome study. And in that clinical outcome study, what they looked at was patients engaged in our intensive outpatient program and how things look 12 months post initial engagement. Now, these veterans were also receiving care at the VA, and again, we work collaboratively as partners with the VA. And what the study showed was that over that 12-month period, veterans experienced a significant reduction in emergency department utilization, fewer all-cause hospital admissions, as well as an increase in VA primary care services, as well as other services that provide for social determinants of health. This is a great example of how a care model where the VA and a community provider work hand in hand collaboratively will be and can be in the best interest of veterans and their families. And so with the VA Mission Act, again, as good and valuable as it is only as good as its implementation. And right now, we believe that without the clear oversight, without the accountability measures, we, providers like us, get grouped into the other provider group, and we are treated in an adversarial light, and we cannot work in the best interest of veterans. And I provide a lot of detail on the testimony, but I do want to highlight what happens when veterans can't get the care they need. I'd like to tell a story of Casey. Casey went to a VA hospital seeking care for post-traumatic stress for his service. The VA failed to provide that care in a timely manner. He self-medicated with alcohol. Over the next months, with no clear sight and a solution in mind, decided to end his life with a firearm. Fortunately, this has a miraculous ending. He's here with me today, and he's dedicated his life to making sure that no veteran suffers what he went through. Chairwoman Brownlee, Ranking Member Bergman, and honorable members of Health and Subcommittee, this concludes my statement. We would be happy to answer any questions you might have.
Thank you very, very much, Mr. Freeman. And I know this committee would like to recognize your brother for his service. Thank you, Captain, for your service to our country. And let me just apologize to you on behalf of our country, really, to say that you should never, ever have to go through losing 40 or more people under your command, leaving the military, coming home, and committing suicide. And suicide in mental health is a huge issue that we have to conquer, and it's an absolute must. And we're moving forward with significant and hopefully successful legislation to move the dial on this, which we have not done, actually, over the years. We have people like Forge who are helping us move that needle, but we really need to move needle quite significantly. So we thank you. And Casey, who is here, we thank you for your service, and thank you for being with us here today. And I know your journey has been a tough one, and we thank you and recognize you for your courage. So thank you for that. So with that, I'll now recognize myself for 5 minutes of questions. So thank you, for your testimony, and really thank you for your service. There's no question in my mind that you're providing, high quality, successful services to our nation's veterans. My first question is, I really don't know, do you span and service the entire United States, or are you just a regional, provide services regionally?
Apologies. As of right now, we're regionally based, and so in the Mid-Atlantic, Virginia, and Northeast.
In the Northeast. Okay, so that would span 2 different areas of, the way the country is divided for community care, just one? Okay. So I guess my question to you is, you have to work with different VA facilities as you cover these areas. Do you find that some facilities are better than others, and do you find that there are some locations that you would qualify as doing a really good job, and others that are doing, are really underperforming in a significant way?
Yeah, so I would say across the board, we actually have no issues with the care that's provided at the VA or the VA care providers. What the issue is from the administrative side. There could be.
Well, that's what I'm trying to address. In terms of the administrative side, what you have to deal with, are you finding some locations that are doing a good job communicating with you and doing what they need to do on a timely basis? And do you find some that are just truly underperforming?
Yes, absolutely. For example, we have in one specific location, we actually have monthly care team meetings with VA clinicians, our clinicians and VA clinicians. That's how tightly we work together. In others, we can't even get in touch with the right people, and there's no recourse if a veteran is not given a proper authorization, or if there's some reason why we need to speak and raise some concern about being a community care provider.
Very good. And you also mentioned in your testimony how one of your clinics has served 41 veterans over the last year who met Mission Act eligibility for appointment wait times or driving distances to the medical facility. But none of these 41 veterans has successfully obtained a community care authorization from the VA. Obviously, this means that you can't bill the VA, et cetera. How do you make up differences like that in your bottom line? And I presume that the VA is well aware of these 41 referrals, and hopefully by highlighting them today in the committee that these will get resolved. But how do you handle that?
It's not sustainable. So we scholarship. We have to. It's not like, okay, there's other solutions. There is a VA nearby that can do this. It's not the case at all. So, the care that we provide, intensive outpatient, is not provided at every VA medical facility. We opened up in Westmoreland, Pennsylvania, Westmoreland County, purposefully because the closest VA medical facility that provides intensive outpatient is Pittsburgh, over an hour away. So these veterans have no other option. And as a mission-driven company, we're scholarshiping them. And so again, we're hopeful that we're doing that. I can't imagine what other community providers are doing when they aren't able to get referrals, because in the private side of the world, you would be discharged from that program.
And would you say the intensive out care is of? I know you in your testimony you talked about, just services, sort of on the outside on a that are non-intensive, I think is the way you categorized it, and then intensive, and then inpatient intensive. And so would you say the outside intensive is the biggest category of need for the veterans you serve?
Yes, without a doubt. And it's because, again, these are for veterans who have a moderate to severe mental health or substance use diagnosis. And so just getting access to mental health care isn't helpful. It might actually do more harm, because just getting an intake without, follow-up appointment being in a month when that person needs 9 to 19 hours of therapy a week isn't really helpful. And also, they don't want to potentially go inpatient. They might need childcare, they have families, job, et cetera. And so this is that middle ground and fills a critical gap. And a lot of the veterans, especially those who are at risk for suicide, intensive outpatient is critical for them.
And are you aware of other nonprofits like yourself that are providing similar services in other parts of the country?
In the private side, yes. It is nationally recognized level of care. It's provided across the nation.
Well, one thing I don't know in terms of intensive outpatient care, I have no idea sitting here what how much of that the VA provides, within their internal system. I know they have inpatient services. I've traveled and seen many of them, but I don't really know how much, intensive outpatient. And I know for for the other category of non-intensive outpatient, I think we do probably a pretty good job, in that arena. But I have no idea, really. We need to, I should know the answer to that question. So anyway, I've gone over my time. I yield to General Bergman for 5 minutes. General Bergman yields to Mr. Rosendahl. I didn't see you there. You left and then you came back.
No, I just scooped down.
Yeah, you scooped back.
Thank you, Madam Chair. Appreciate it. Thank you, Mr. Freeman. Appreciate you being here, Mr. Skolnick, everybody. This is really, really important issues. I've been working with the Wounded Warriors and the Warriors with Quiet Waters out in Montana, trying to find different ways to address some of these PTSD issues and to get our veterans healing holistically. Okay, the best way it's possible. I appreciate that you testified that the VA serves an important role in the care of American veterans, especially in a state like Montana. Community care can be critical because of the rural nature of the state and the distances that we have to go through. It sounds like some of the facilities that you're working with in the Middle Atlantic area embrace the concept, and others don't, as far as having this collaboration. And it sounds like some of them are actually embracing it very well if you're having joint meetings. So my question would be, and to whichever one feels like they're best prepared to answer it, is this something that is a rule or statutory problem, or is this a cultural problem within the different facilities? Because we constantly hear that every facility is unique.
Yeah, so actually, one of the things that I do want to mention is that the individuals providing care at the VA are amazing. So to answer your question, it's 99.99% of the individuals, especially for the administration side, could be fantastic. That 0.01 is what could be the holdup. And so yes, it is a culture of the individual medical facilities or the BISN.
Okay. So in the previous panel, I referenced the 7-step process required before a veteran can be seen by a community provider. What's your understanding of this process from the provider side, and how could that be improved?
That is a great question. And so I think something that could be helpful is differentiating between high acuity services and low acuity services. And I know that there is for urgent and emergency care versus not, but when a veteran needs mental health or substance use care, if that person doesn't get help pretty much immediately, we believe that number is actually 24 hours. Yeah.
I
I
was going to say, just as a veteran who's been through the journey myself, right? You've got a very short window, and I've also lost a lot of friends to suicide and a lot of friends to overdoses over the years that I served with. You've got about 48 hours to get somebody in there. Whether it's a bureaucratic issue or a cultural issue, the real problem is they're not getting care that they need in a timely manner.
Right, and that's what we're trying to do here, is to take that window of time and shorten it down, because if I ever hear a consistent complaint from veterans, it's about the delivery of the time frame with which they can get the care. And so do you have any recommendations about this 7-step process, how we can shorten that down, eliminate it, whatever, so that we can get that care delivered faster?
Something that I can just recommend is that what we work with commercial health insurance companies as well. And so what they do is, if we begin the authorization process and start treating the patient, and the authorization process might take a little bit of time, if it's approved, it starts on the date that we started treating that patient, not when the date of approval, which is currently the way the community care referral process goes. It begins on the date of the referral was generated. And so you can't backdate that care. And so that could just be one suggestion among others we provide.
Okay, that is a good suggestion. When Forge Health encounters someone seeking health for substance abuse, what is the time frame that you're experiencing now for them to get treatment before they're likely to have a relapse or their condition would worsen?
24 to 48 hours.
Yeah. And so what kind of time frame are you dealing with, though, to actually get them in there and get this approved?
We're not even worrying about that. We're getting them into treatment immediately, and we'll worry about it on the back end with the veteran, which is not ideal, right, just from our perspective. But at the end of the day, the most important thing is the veteran and getting them into treatment immediately.
Okay. Madam Chair, I'm about down to it. I have some extra time, but I'll go ahead and yield back. Thank you.
Thank you, Congressman, and now recognize General Bergman.
Thank you, Madam Chairwoman, and thank all of you who've worn the cloth of our nation. And Mr. Freeman, you've been shouldering the load of the response here, and I noticed Mr. Golnick was he was about ready to punch you in the arm there to get his turn to talk. So if you'll share the mic with him a little bit, that's okay. But what I sensed in looking at both of you and those who are with you, the passion, not emotion, but passion with which you've attacked the situation of especially veterans' mental health. So I can't thank you enough for the endeavor that you've embarked upon, because you will make a difference. Do you think that referrals for care for veterans seeking treatment for substance abuse issues should be considered urgent rather than routine? And would you just care to just say why?
And Eric, feel free to jump in on this as well, but it's vital, right? I'm somebody that suffered from substance use issues when I got out of the military. And if somebody told me to go back and come back to get an appointment 6 weeks to 8 weeks later, first place I'd go is to the bar, right? And this is where you start losing folks, right? This is where you start getting issues start coming up, personal, post-traumatic stress, things that come up. There is a very short period of time that if somebody gets enough courage to ask for help, to get them into treatment, right? That's an urgent thing, right? Our suicide numbers, if you look at the VA's data of suicide numbers, substance use issues are there's a large correlation between substance use issues and suicidality, right? So it is urgent because people are going to die if you don't get them into treatment fast.
Okay. I know you've stated what you just stated to the VA folks as well. What's their response been when you tried to create if you will, in their mind, the understanding, the sense of urgency with getting veterans into the system quickly when they're at risk?
The conversations I've had with folks like Dr. Matt Miller at Suicide Prevention, we actually did an op-ed on this together at VA. They're very positive, right? It's understandable that substance use is a major issue. I think there's what Eric Freeman mentioned, there's a disconnect somewhere at an administrative level that's causing it to not be taken in, I don't want to say not in a serious manner, but it's not being taken as serious as it should be.
Okay. You were listening to the first panel and the answers to the testimony, and I'm guessing you sensed a little bit of frustration up here on this end of the mic of not being able to see not only a timeline, but the wickets that must be jumped through. Would you, as an example of that care in the community provider for this unique situation, be willing, if this committee, I'm not going to say charter something, but suggested to the VA that you put together, in the Marine Corps we would have called it a tiger team or something, some kind of an OPT, whatever it happens to be, to work together to lay out the scenario. You're living it, the VA is trying to understand it, and we, as members of the committee, are trying to look at and see the whole, if you will, the sequence of events that occur to see where the challenges are, where the lack of communications are, not intentionally, just accidentally, because you haven't put together that seamless team yet to, in the end, make sure that the veteran gets the care immediately rather than on a routine or basis. Would you guys be able to devote some time to that?
Absolutely, no doubt. And we're already partnered with the Office of Suicide Prevention and Mental Health. I'm not sure which office we would work with this specific, but we're more than willing to work with anybody within VA to really push this.
Well, Madam Chairwoman, I think, as members of the committee here, that if we can get if you will, the two sides here working together, just gives some kind of, I'm not going to say a pilot project, I'm going to say, or maybe a demonstration, or just to work through steps A through Z and how this works. Maybe we can all get a better visibility and not put the burden on the VA to come up with it on their own. Because usually what I've seen is good results come from, I hate to say customer input, but companies get better or entities get better because they work with their clients to smooth things out. And with that, I thank you for your testimony and your commitment to all of our veterans and their families for what you do. And with that, I yield back.
Thank you, General Bergman, and I think we've got a few more minutes, so I'm going to give myself 5 minutes more for questions, and if anybody else would like additional time, I will provide it. So what do you do when veterans come to you, they've had no association with the VA whatsoever, and it's clear that they need help from your organization? What we have learned around suicide anyway is that, there is a portion of those who commit suicide who have never reached out to the VA before. So they're out there. And so what do you do for those veterans? And do you do any kind of sort of outreach at all so that veterans know that you stand ready to help them in your communities?
Yeah, absolutely. And what we do is, and a primary goal of our partnership with VA is when veterans come to us for substance abuse, mental health issues, the most important question that we ask after obviously addressing the immediate needs is, are you connected to the VA? When's the last time you saw your primary care physician? Do you need any, what about specialty care? And then we connect that veteran with the local VA medical facility.
Well, wonder if you determine there is an urgent critical need. Would you just send them to a hospital at that point, or what would you do exactly?
It depends on our relationship with the local VA medical facility, but if they have an urgent need, it's whatever's going to be immediate. And so whether that's calling 911 and having someone taken to a hospital, But if it's for the inpatient side, so let's say, someone comes to us, outpatient, needs inpatient, yeah, that referral is, or, yeah, that connection is going to the VA.
Right. And so when you were in the military and you left the military, were you ever given, in your TAP or, transitioning out to civilian life, were you ever given any information at all that, drug addiction, suicide, is something that you should look out for, that we recognize that some of our men and women who serve leave the military and face these kinds of problems?
No, I'm sure, ma'am, there are plenty of great TAP programs out there. A lot of them are kind of just a check in the box as you're leaving a command. I think there could be a better job done in terms of explaining those issues and really explaining what resources are out there. I did not have those. I was told what to do with disability. I was told how to get your medical records to the VA. I was not told about anything with post-traumatic stress. And again, this was years ago. This was, I'm getting old now, so.
Yeah.
But it was, there definitely could be a lot more done on that.
Yeah, so do you think if you had been aware of all of the elements around, all the indicators, I should say, around post-traumatic stress, what that can lead to, that if you had known that, do you think you would have reached out to the VA before you reached out to other substances?
I think there's a stigma around substance use where, especially as you're getting out of the military and you're thinking about your next career move, that's not something you want to concentrate and talk about as much. So I think ways to break down that stigma around that would be vital as a conversation to have with folks as well. That it's not weak to ask for help and it's not weak that you have these issues.
Very good. So I have a minute left. Is there anything that I haven't asked that we should know before we close? I know that there's going to be a small meeting after this to get this issue about inpatient, intensive inpatient services resolved. I think Optum is here, so the three of you can get together. But if there's anything that we should know that we haven't really highlighted.
This has been fantastic and for us, incredibly encouraging. It's not easy to implement something like the VA Mission Act, and so having these conversations is critical. So thank you.
And thank you for all the hard work this committee does. So thank you.
Yeah, well, thank you for that. And I think, I think the two big takeaways from this hearing is we've got to find, the right balance between services from the VA and services from the community and figuring that out. And none of you are saying that the VA shouldn't be doing what they should be doing. You're saying, the VA should be doing what they should be doing, that you are there to augment and provide a multiplier to the services. And the other point that you have made very, very clearly is, we're only as good as the implementation. So this program is only as good as its implementation. And I think we are well aware of some of the bottlenecks within the implementation. And it's certainly our desire to take the necessary steps and to work with the VA. And I think you can be, as General Bergman was saying, can be a really important component to helping to solve some of these issues moving forward. So, we really very much thank you for being here. Thank you, most importantly, for what you do every day for our nation's veterans. It gives me greater confidence that there are organizations like yourself that are out there doing really, really good work, because the VA can't do this alone, and that we're all in this together, and that we do absolutely need to address this suicide rate. One suicide rate is too many. And I believe, and I think all of us believe, it's solvable if we put our minds to it. So thank you very, very much for your testimony. And General Bergman, any closing remarks?
Thanks, Chairwoman Brownlee, for chairing the hearing. Thank you, gentlemen, for all you've done, and I know you will never leave anyone behind.
With that, again, thank you for being here, and seeing no other questions. With that, all members will have 5 legislative days to revise and extend their remarks and include extraneous materials. Without objection, the subcommittee stands adjourned. Thank you.